So why don't we always do this if it's so good? Well, there are a number of downsides to it, and uh, it's not something we always do or always have to do. It is a little bit more complicated. It's more complicated and it takes more time than just cutting it out, sewing it back together, because that whole process of looking at the wrapper under the microscope takes time. And each time you find that there wasn't a complete removal, that there's still cancer in one of those areas, you've got to go back and take some more and keep taking more until it's completely out. This means you could end up with a very irregularly shaped wound. And now you got to figure out a complicated way to put that back together. And it may be too complicated for the dermatologist to do that day under local anesthesia. So it's not unusual that Mohs at the end has an unusual or complicated defect in a cosmetically sensitive area, and the patient has to go to a plastic surgeon, maybe a day or two later. In the meantime, just having a bandage on their wound, and the plastic surgeon then has to figure out how they're going to reconstruct it so that it's got a good appearance and it heals up. You don't know beforehand what you're going to get when you unpeel that wrapper. Excuse me. Second disadvantage, it has to be done pretty much across the board. It's done under local, and we can be dealing with areas that are very sensitive, and not everybody likes to have surgery under local. So surgeons who can put the patient to sleep or do the procedure under sedation, perfectly reasonable alternative to Mohs surgery to do it that way. And the third issue is that the person looking at the slides is a Mohs dermatologist, usually, not necessarily a specialized pathologist. Some surgeons are very specialized and do a lot of pathology, others not so much. Most of the time, like with that Reese's analogy, it's pretty obvious. You don't need to be a pathologist to tell the difference between the chocolate and the wrapper. But there may be information in there, prognostic information, or changes in the chocolate itself, or the peanut butter in the center, that only a pathologist would recognize. So sometimes it's very important for that central component, that Reese's cup in this analogy, to get looked at by the pathologist, even after the Mohs surgeon has looked at the wrapper. And of course, if we do a standard surgery, the pathologist is always seeing it. And as I said, it can almost always be done under local or under anesthesia. There's an option for either one. And usually we have an idea right at the beginning. I'm going to do the incision that's this size. I know what I'm going to do to repair the defect, and I know what I'm going to do if the margin turns out to be positive and I have to do something additional to cure it.